Patient to STATS post-Whipple for pancreatic cancer with recurrence, comes with cholangitis because of afferent loop syndrome. So we see the liver, and if we follow towards the hilum or here hepatojejunostomy, we're going to see this dilated loop of small bowel. You see fluoroscopy here, but we're not going to need it because we can understand that we know for sure this is the afferent loop because Ken here is showing you the pancreatic stent. Patient has a surgical pancreatic stent in place, and you see it here. And also we followed the loop towards the hepatojejunostomy. So we don't need to inject. We know this is the afferent loop. So there are some small varices in the way, and this is actually a frequent occurrence in these patients. So what we want to do is, of course, avoid the large varices. But if it's something small in between, I think it's okay. The best way not to see varices, Ken, is to turn it off. Yeah, deflect it a little bit away from those varices and just pass them and then go back to the original position.
I think also in terms of the direction of your stent placement, this is a better position now. No?
Yeah, so fluoro, let's see fluoro.
Burning the stent through the wall, he will have plenty of space in front of him, so he would like to have the jejunum here in the longitudinal axis, what's the case right now. And the second reason is that here is used to treat afferent loop syndrome, but if you have to go through the stent and perform ESCP, you would like to place the stent towards the biliary enteric anastomosis. What's the case here now? So so we had a lot of cases when we had to struggle after that to go to the anastomosis with the scope. So this is a very good position.
Yeah, otherwise you have to make a 180-degree angle to get to the HJ, which is difficult. So here we're just going to use a standard Ben-Moller technique and Kari, and we are in. And how do you know we're in, Ken?
I'm actually, are you sure you're in? I see the bubbles. But yeah, there you go. Okay.
This is
I do
very
see the
important to
bubble.
be sure.
Okay, so now we're gonna go. And can we switch to end of view, please? So there is also, you know, you see the bubbles, you see the catheter.
Yeah.
And also there is a tactile feedback, right?
That's right.
So that's why when you go, you want to go slowly.
Yeah.
Let the cautery do its effect, and so that also it gives you the feedback. If you're doing like an FNA, you're going to push the target away, but also you lose that tactile feedback. Now deploy the second flange in the inside the scope. And this is 15-15, so you have a lot of leeway here. Clean the lens.
Once you can see the stent in the end of view, so you're safe, huh?
Yeah. You switch to the endoscopic view now. You see the saddle there, and you're going to push now the proximal flange out of the working channel. And you're going to see it open up, and you've got a little bit of distance to the wall, so you don't accidentally pull out the distal flange. And now you see the retained contents in the afferent loop draining.
Yeah, if I need to do an ERCP, and I've actually had these patients with stones.
Yeah.
Then you want to put a larger stent, probably a 20, and dilate. You don't have to dilate to 20, dilate maybe 15 to 18 max.
Yeah.
And I would suture it.
Okay.
And do an ERCP using a therapeutic upper scope.
Okay. I've never sutured one in, but I have to say, I make sure that I instill vegetable oil. We call it sweet oil, is what we have in the unit. I make sure that I instill it inside of the saddle. I lubricate the shaft of the duodenoscope very generously, and I'm very cautious as I'm going through, but it has to be a 20.
Yeah.
And I've never dislodged an Axios. And you agree there's no indication to dilate this, right? You leave it. You're not going to dilate.
No,
right.
So
Just to be clear.
Yeah, the only time we dilate is walled off necrosis that's infected.
Yeah.
Immediate drainage and then etch.
Yeah.
You know, so but other than that, let it dilate by itself. We've had dislodgements during dilation.
Yeah.
And you can get significant bleeding
And pain. Patients
yeah.
have pain afterwards.
And in this patient, we know there are varices around, you know, and
true.
usually you lacerate varices or vessels around the axis during dilation.
That's
and
right.
this can be hard to treat.